Hello and welcome from Bozeman, Montana. In Montana, we have a significant lack of access to evidence-based perioperative surgical services. As a rural community hospital, we have a new pre-anesthesia outpatient clinic, and it's one of Montana's only health systems using an evidence-based perioperative surgical home model to optimize our patients for surgery. Our health system provides services to a rural tri-county area that spans 9,000 square miles and 132,000 residents. We have an 83-bed facility, and it's accredited and licensed Level 3 trauma center. As you can see in Figure 1, our perioperative care stakeholders include our anesthesiologists, our surgeons, our patients, as well as their families. And our goal is to optimize under unideal conditions. We have limited microsystem supports, and so we're trying to engage with both our patients, their families, and our surgeons, as well as other clinicians through co-management to optimize our patients before, during, and after surgery. We created a system model using field-based user observations during normal clinic operations, investigator-led debriefs of all primary staff members, and we tracked longitudinally 20 patients prospectively. We created multiple iterative models and did rapid improvement iterations until we had the ideal patient flows through the clinic. As you can see in Figure 2, we have our preoperative visit flow analyses. We use process mapping, the critical path method, bottleneck analyses, and cause and effect diagram to enable us to create the POSH system diagram and to create a system that could better meet both the staff and patient needs before their surgery. Here on the lower right in Figure 3, we have our POSH preoperative visit, and what we were able to do was determine which area of our outpatient visits, our pre-op visit, was taking the most time so we could better optimize not only quality and safety of our patient care, but ensure that we could meet our ever-increasing demand of our peri-op services. So the average visit time was 70 minutes with a standard deviation of 24 minutes for our 20 patients that we tracked prospectively. Since the clinic's volume had been rapidly increasing, we had to revise some processes to decrease visit time, including handoffs, consultation, and documentation procedures. One of the cornerstones of our POSH model is physician co-management, and we found that to be very important in this process. There is very limited POSH evidence for rural healthcare facilities. The team analyzed POSH implementation with limited supporting microsystems. Clinicians and system engineers created a system model to coordinate rural surgical care across an expansive and siloed network in Montana. The POSH's preoperative sleep apnea screening, post-acute inpatient care scheduling were determined to be significant bottlenecks in our rural POSH system. Since the rural pre-anesthesia clinic opened, we have seen decreases in average length of stay as well as readmissions, and we've improved our patient satisfaction. Our patient engagement throughout the perioperative period has been critical and challenging given the expansive siloed network that we operate in.